Thank you, Mr. Chairman. And again, it's a pleasure and privilege and an honor for me to be with you electronically at your meeting in Marakech. This talk is entitled, Despite the Randomized Controlled Trials and Much Registry Data, to the contrary, the future outlook for carotid stenting, or CAS, is bright. Carotid stenting, or CAS, is currently in decline for the treatment of symptomatic and asymptomatic carotid stenosis. This is because with symptomatic carotid stenosis patients, randomized controlled trials and all registry data, as recently reviewed by Paraskevas and Naylor, show higher stroke rates with CAS than CEA. And with most asymptomatic carotid stenosis patients, best medical treatment has such low stroke rates that it possibly makes CAS and CEA unnecessary. The evidence for this is shown here, where you can see that the annual stroke rate with asymptomatic carotid stenosis has decreased due to better medical treatment and statins from 3 to 6% per year in 1985 to less than 1% per year now. However, I believe the outlook for CAS is bright because 3 advances may decrease strokes, improve CAS results, and make the current randomized trials and old registry data obsolete. These advances are better embolic protection devices with cessation or reversal of flow, the MoMA device being one, cervical access with the TCAR Silk Road system to avoid the aortic arch and reverse flow, and thirdly, membrane or mesh-covered stents to stop delayed strokes. Here you see the particulate matter released by carotid stenting and which causes strokes. Here on your left, you can see a cross-section of a very high-grade carotid stenosis with a pinpoint lumen that is indicated by the black arrow. And on your right, you can see the restored lumen in that lesion by placement of a stent and expansion of the stent. And you can also see, as indicated by the white arrows, the debris that is protruding through the stent, and it is this debris which gets washed off by the blood flow to cause delayed emboli and delayed strokes. And here is a mesh-covered stent which can prevent delayed embolization by preventing the plaque fragments from protruding through the stent as it is expanded. 3 such micromesh carotid stents have been produced by various industry partners, one from the Gore Company, one from Inspire MD called the Seaguard micromesh stent, and one from Terumo called the Road Saver stent. Trials of all 3 of these mesh-covered stents have been promising, but we need more, and particularly more late results, to be sure these mesh-covered stents don't increase late carotid stenosis after CAS. For both symptomatic and asymptomatic patients, if these 3 advances decrease CAS stroke rates, CAS would be more competitive to CEA, and CAS would replace CEA more widely than it now does. In addition, for asymptomatic patients, there are promising ways on the horizon to select those at high risk of stroke. These include TCD-detected microemboli, various methods for duplex plaque evaluation, MRI and CT plaque evaluation, silent MRI and CT brain infarcts. With these techniques, some asymptomatic patient groups can have over a 12% per year stroke risk compared to less than 1% for the group. These high-risk asymptomatic patients selected by these methods clearly would benefit from CAS or CEA in addition to best medical treatment, thus increasing the number of patients needing CAS. However, there is one very important reservation. That is, the efficacy of these methods for decreasing CAS stroke rates and improving asymptomatic patient selection must be proven by appropriate clinical trials. In light of all this, my conclusions are, first, despite this reservation, I believe the outlook for carotid stenting, or CAS, is bright in the future. And second, all vascular specialists and vascular surgeons should prepare for improving CAS results. Thanks for your attention, and thanks for having me.